All right, so welcome. My name is Vic Anand. I am a pediatrician in the United States. I specialize in pediatric infectious diseases. I wanted to talk about measles, obviously, since there's a growing outbreak. And this talk is geared towards clinicians, so general pediatricians, uh, urgent care docs, ER docs, family medicine, nurse practitioners, anybody who's seeing kids, especially on a daily basis. Just to go over what measles is, this is going to focus mostly on clinical, although towards the end maybe we'll get into the weeds a little. Feel free to stop at any point. This talk is licensed under Creative Commons, so feel free to redistribute it, modify it, translate it, whatever you want. Just does have attribution, so if you do find that a little tiny bit of credit is all I'm asking for. Mostly because I need it for my resume. Um, so let us get into this. I think unfortunately we're going to just be seeing more and more measles as vaccine rates decline. And that's just the reality that I think we're all going to be facing. So I think it's important to be able to recognize it. Um, so quick facts about measles. Historically known as rubeola. It is a virus, which I think most people would know. It is the most contagious infectious disease that we know of, which is why you need really high percentage of vaccination rates or prior immunity in order to prevent outbreaks from occurring. There is no known treatment for measles, meaning there's no once measles gets going, there's no real cure. Now, that's not to say we can't prevent or at least attenuate illness severity in some cases, but we don't have like a magic bullet cure for it. The most important thing to remember is that 2 doses of the MMR vaccine can prevent 97% of measles infections, and most of those other 3%, if assuming you're not immunocompromised or something, it probably also prevents more severe illness. All right. So I think the most important thing to remember, the obvious thing that I think most people think about with measles, right, is the rash, because it's so characteristic of measles. But I think the more important thing to remember is that measles is a respiratory infection. It is a respiratory virus. It's actually in the family of paramyxoviruses, which includes RSV, human metapneumovirus, parainfluenza. So if you can imagine its cousins and how much they cause respiratory illness, remember that measles is related to them. Um, the rash, of course, being very characteristic, that is what we describe as a morbilliform rash, which means it's a blanching maculopapular rash that begins on the face, upper neck, and upper chest, and then spreads centrifugally outwards as it evolves. More and more of these spots pop up, and they start to coalesce into these groups. There can be some petechiae to it. After it starts to fade, frequently will peel, and sometimes it's a little bit painful. So children might complain of either itchiness or burning discomfort. The other clinical characteristic of measles is these things called Koplik spots. This is the enanthem of measles. This is the exanthem. So the enanthem of measles, Koplik spots are these whitish, sometimes bluish, although I think they're pretty much always whitish, with an erythematous base. And so you can see a nice one here. There's a nice one here. And as they progress, they will start, just like the exanthem, you'll get more and more of them, and they'll start to coalesce into these groupings. So you can see here there's a bunch of them with an erythematous patch as the base. I think what's most important, though, to remember on measles is that it goes through a very classic clinical course, and it's really important to understand that and the nuances of that because it matters. So let's just let's just draw a timeline here. Oop. My tablet will cooperate. All right. So let us draw a timeline. All right. That's good enough. So let's say you've got this little kid. Let's call him Johnny. And Johnny comes into your office and he's sick, so he's going to be sad. And he is coughing up a storm in your waiting room. And when he's coughing, or yelling, or crying, or carrying on, or laughing even, he is producing these tiny little respiratory droplets. And these droplets are so fine that they hang out in the air. And unfortunately, he's got measles, although we don't know it yet. And so these little droplets will hang out in the air, and they contain measles, virions, or viral particles. And you really don't, remember I said it was the most contagious disease, you really don't need a lot of those particles to enter into some other person who's either unimmune or unimmunized and hit your mucosal surface and start the measles infection, which is why it's so contagious. And remember, these droplets can contain thousands, if not millions, of viral particles. So he's out there coughing, and then little Susie comes in, and she is also unvaccinated. And she's here for a well child check, so she's happy for now. And the thing to realize about this is that what is the likelihood that she is going to get infected being, around this kid, or even up to 1 to 2 hours afterwards? These tiny little respiratory droplets can hang around the air. There is a 90% chance that someone with a reasonably close contact with someone with measles, or in the same room or domicile, will get infected. So it is a very high risk of an unimmunized person getting it once they're exposed. But here's where the catch is. So let's call this day 0. This is when she was exposed to measles. She is actually not going to end up getting sick for about 10 days. And that's going to be important when we talk about secondary prevention. But for about 10 days, give or take between 7 and 14 days would be the sort of the range, with 10 being the most likely. She's not going to have any symptoms whatsoever. She's going to go about her day. Meanwhile, of course, measles is starting to replicate in the nose and in the upper respiratory tract, and starting to spread, and is maybe even starting to become viremic towards the end of that course. And but she's not going to have any symptoms. So this is the subclinical stage, the subclinical incubation phase. And then at day 10, symptoms are going to begin. And what are the symptoms? So here we have day 10. So, you'd hope that the first symptom you see, right, is this beautiful measles rash, right? And, you can make the diagnosis right then and there, but that is unfortunately not the first symptom that is going to pop up. The first symptom that's going to pop up, if you remember from med school, is going to be fever, of course, and then the 3 C's. And the 3 C's stand for cough, coryza, and coryza is just Greek for bubbling, so if you can imagine, it's like very watery eyes, a lot of nasal congestion and clear, nasal discharge, a lot of phlegm in the throat, and kind of a wet-sounding cough. So that's coryza, and then the last C is conjunctivitis. And it's not a particularly characteristic conjunctivitis. It's, bilateral erythematous conjunctiva, typically non-exudative, so you might see some clear discharge, some mucoid discharge, very typical of like a viral pink eye, and not really so exudative that you might see, or purulent that you might see in a bacterial conjunctivitis. So anyways, what does this look like to you? Well, I mean, it's going to look like just about any other respiratory virus, right? You got fever, rhinovirus can do these, human metapneumovirus, RSV, all the respiratory adenovirus, right? Especially with pharyngoconjunctival fever, right? You're going to see quite a bit of conjunctivitis with adenovirus cases. So you're going to tell them, hey, it looks like a virus. And you're not wrong. It is a virus. It's just not a regular respiratory virus, right? It's measles that's doing this. And these symptoms are going to last for 48 hours before the next symptom. So 24 to 48 hours later before your next symptom. And is that next symptom the rash yet? Unfortunately, is not. This is when you start to see the Koplik spots form. Oh, no C, just Koplik spots. And Koplik spots are, as we talked about, these whitish lesions on an erythematous base. Koplik spots are pathognomonic for measles, which means if you've got what looks like a upper viral respiratory infection, but you look in their mouth, and especially on the buccal mucosa, or maybe even the soft palate, you see some of these lesions, then you can diagnose measles right then and there. But unfortunately, especially when they first start, they're going to be pretty subtle, and you might end up missing it until they really get going. And this, again, lasts for about 24 to 48 hours before finally you start to see the rash. Let's make the rash red for fun. So now finally you see the characteristic rash, which just about anybody should be able to then go, oh my gosh, this is a case of measles. The rash itself is going to last for about anywhere from 5 to 7 days before it really starts to fade, again starting up here and then moving centrifugally out to the rest of the body. This means that the entire measles duration of illness is anywhere from about 7 to 10 days of illness. The fever will start to break within about 3 to 4 days of fever, and then the rash should also start to fade, and again, it in many cases will peel. So, and sorry, actually, it can go as long as 14 days of fever too, or illness. So, that's the classic clinical story, and the most important part is this right here. For between 2 to 4 days, you've got a kid who's not showing a lot of outward signs of measles other than the respiratory symptoms, probably going to get dragged to the grocery store on a trip because he's got a fever, but it's just a cold, right? And potentially be exposing a lot of people to measles. All right. So what's the big deal with measles? Is it a problem? I think most of us, if you watched the Brady Bunch as a kid, you remember that episode where Marcia, or was it Jan, one of the two, gets the measles, right? And they're painted on her face, and she walks around happily. But the reality is there's not going to be a whole lot of kids who have a fever to 39, 40 degrees Celsius who are going to be feeling very good at all. So most kids will be sick, and they're going to have a pretty bad cough. The thing that matters the most about your outcome for measles is really socioeconomic status. And different outbreaks and different socioeconomic statuses will have very different outcomes. Hospitalization rates, though, even in developed nations, is anywhere between 10 and 30%, depending on the outbreaks that have been studied. And if you look at mortality, which is obviously the most concerning part of measles, if you look at underdeveloped nations or poor countries, there can be mortality rates during outbreaks that are as high as 28%. And a lot of that has to do with the medical establishment and malnourishment, right? If you already have a kid who is underweight, has vitamin deficiencies, and is sick with a number of other different infections or chronic diseases, and then they get a pretty severe viral infection on top of that, you're already set up for a much higher mortality rate. Not to mention, of course, that their hospital systems just cannot handle the burden. If you need a bunch of kids who need intubation or IV fluids or that kind of thing, you are really going to end up strained and unable to provide advanced care. That's the mortality rate in developed nations. If you look from outbreak to outbreak, it has varied pretty significantly. And I tried to look through a bunch of different numbers, and it's really anywhere between 1 in 500 in some outbreaks to, if you look at some of the more recent European outbreaks, it looked like it was more 1 in 3,000 patients will die, and that's in an advanced setting. The highest risk, of course, babies, children less than 2 years old, immunocompromised patients. And actually, older individuals are more at risk as well. And remember, a lot of viruses sort of have this um, bimodal distribution where it's the very young and the very elderly who get sick. Now, the thing about measles, though, is that if you were born before the 1950s, you already got measles, you survived measles, and lived to tell the tale, and you have lifelong immunity. So, how does measles kill? About 1 in 20 patients with measles will develop a severe lower respiratory tract infection with measles. Remember, I told you that it's generally got a pretty bad cough. Well, the reason for that is that it's going down your bronchial tree into your alveoli, and obviously, if it gets severe enough, your lungs fill with fluid, and you get a severe viral pneumonia. And again, a lot of the mortality, especially in underdeveloped nations, is from the pneumonia itself. And I think here where I pulled the figure from was 1 in 500 to 1 in 1,000, but obviously it might be less than that if you have more advanced respiratory support, things like ICU care. The other important thing to remember about measles is that about 10% will develop a secondary bacterial infection, which is quite a lot. Now, fortunately, the majority of those are going to be acute otitis medias, which is very treatable. But any respiratory virus that is severe enough and gets in the lower respiratory tract, remember, it injures the ciliated cells, and those ciliated cells are really important for moving all the bacteria that live in our nose and our mouth that we aspirate on a daily basis back out of the lungs. And when those are injured, those bacteria are there ready to cause a pneumonia. And so if you've got a really sick kid who needs to be in the ICU or is looking septic, there's a very good chance that child with measles might have a secondary bacterial infection and very well may need antibiotics in addition to the rest of the supportive care. But the measles virus itself can cause a severe pneumonia and flood your lungs and put you out of and unfortunately kill you. The other really important thing to remember on measles is it does have a predilection for the CNS. About 1 in 1,000 will develop encephalitis. Of those, a third will die. And importantly, the ones who survive, up to half, may end up, or even more, may end up with some degree of permanent neurological injury, ranging from mild to very severely devastated neurologically. There is unlike enteroviral encephalitis, right, where the vast majority of children obviously strain dependent, but the vast majority of children will recover completely. Measles is a much more virulent virus to the CNS and does cause a lot more injury to neurons. The last important one to remember is SSPE, which stands for subacute sclerosing panencephalitis. Fortunately, it's a very rare complication of measles. That being said, when you have millions of cases, you're going to see some. About 1 in 30,000 to 1 in 100,000 cases of measles will develop this. But what's really important to remember about it is that it happens years after the measles case. So 2 years, 4 years, even 6 years after the measles, after the child has had measles, long after anybody even remembers that child has measles in their history, they begin to start subacutely, right? And that's where it got its term. You'll see things like declining school performance, cognitive delays, attention issues, things that you might and very frequently wouldn't attribute to an infection or a neurologic process. Like, hey, maybe they're having behavioral problems, maybe we need that kind of thing. And over the course of weeks and months, is where the cognition continues to decline, and starts to become obvious when they have their first seizure or they're acting delirious or something like that, that it really becomes apparent, oh my gosh, there's something organically going on. You get an MRI and you see all these white matter lesions everywhere, and it's that insidious onset that I think is so scary, and it's universally fatal. We don't have any treatment once it starts. So, first of all, before we get into this, I think let's have a look at how we're doing in this current outbreak. So, the date is April 3rd, and so far there have been, as of the last update, 483 cases in the US. As you can see, the majority were in children. There is a hospitalization rate right now of 14%. And remember, it's really important to remember, we don't hospitalize children to quarantine them, right? I mean, what insurance company is going to pay for that? So kids who get it, we ask them to go home and isolate, and please be responsible so they're not spreading it. But there is no, we don't admit them to the hospital just because they've got measles. We admit them because they're sick enough to warrant it. They've got terrible diarrhea, they've got terrible breathing, they're sick, their vital signs are abnormal. Any of those things that would make us worried that this could really go downhill. So, that's in that 10 to 30% range. So nothing really surprising there. There have thus far been 2 deaths associated with measles. If you look at this little asterisk down here, there was 1 confirmed death and then 1 death that's under investigation still. It's been saying that for a while, so I don't know what more they're doing before they confirm it, but presumably ensuring that it wasn't from another cause. If you just look at that number, that's 2 in 500 or 1 in 250, but I think it's much more likely that this number will continue to grow significantly before we see this number growing much further. All right. So let's do a little thought experiment. Like, what happens if no one is vaccinated? Let's say some people get their wish and there's no more measles vaccines that are allowed to give to children, and they're banned, and now we can all get natural measles, and supposedly that's going to be great for us. Well, before the vaccine era, right, the vaccine was developed in the 1960s, everybody got measles, right? Just about any child who was born in the United States or in the rest of the world, by the time they were 15 years old, I mean, it was almost universal that children got it. There would always be a few people who managed to escape, but the vast majority would get infected. So if you think about it, in the U.S., we've got about 3.6 million new births every year. So that's 3.6 million new teeny tiny cute babies who are ready to grow up. And if all of them remain unvaccinated at some point in their life, and it'll start out slower and then ramp up, they would all get measles. And if you think about the conservative mortality rate of 1 in 3,000, that means about 1,200 children each year would die of measles, which is obviously a pretty horrific number to think about when we can prevent essentially all of those children from getting infected and dying. So, again, most children will live, but we can at least do much better than 1,200 unnecessary dead children each year. So talking about prevention, to quote Ben Franklin, right, an ounce of prevention is worth a pound of cure, and that's especially true in this case because we do not have a cure for measles. So if you get measles and you are in the full blown, you start having fevers and stuff, we do not have a cure for you. We just have to help you through it. So if we can prevent it, let's do that. And the best way to do that, of course, is the MMR. The MMR vaccine is only offered as a combination, so you get measles, mumps, and rubella, 3 for the price of 1. And it is 93% effective after one dose, providing long-term immunity. And two doses are 97% effective. And the reason for that is when we only did one dose. So if you're like an old Gen Xer like me, right, and you got these forehead wrinkles that don't go away when you stop scowling, and your hair is going, and you have a love of flannel shirts and listen to way too much Nirvana, so your hearing's going. All of those people, like me, got one dose. And the reality of that was, even at 93% of effectiveness, we were still seeing little breakthrough outbreaks because of that, and hence why we realized that we needed to be even higher up to 95%. And so that second dose really prevents that, and you can eliminate measles if you achieve 97% immunization rates. If you happen to be like me, just for fun, if you just got the one dose, you can absolutely get a second dose. Or, like for instance, for my work, I had to prove that I had measles immunoglobulin with a blood test, and that was sufficient to say, okay, I've generated long-term immunity. But otherwise would have needed a second one. If you're an old boomer, then you born before 1957, you almost undoubtedly had measles when you were a kid, and you have lifelong natural immunity. All right. So, talking about the vaccine, of course, it comes in two flavors, the MMR and actually the MMRV. And I'll tell you why it's important to just note that distinction in your practice. The usual schedule is two doses at age 1 and then 4 years of age. There's no need necessarily for that 3-year gap. That's just sort of how we did it, so you wouldn't have to have a 1-year-old come back in a month for a second dose. Of course, in an outbreak setting, you might want to consider moving that MMR vaccine, that second MMR vaccine, to a 4-week period, just to give them that extra protection. The one caveat to that is be careful if you in your practice are using the MMRV. You need a 3-month 3-month delay between the two doses because of the varicella component. It needs 3 months. That's how it was studied for its efficacy in between the two doses. A lot of questions I've been getting recently have been, can I vaccinate younger children? And the answer is yes. You can actually vaccinate down to 6 months of age. The question is, should you vaccinate younger? And that depends. Probably the most notable reason that we would recommend somebody younger than 1 year of age getting it is to travel. If you travel to, for instance, Europe, it turns out that Europe has its own problem with measles. You think about the French guy going, we are better than you stupid Americans. But the reality is they have their own problem with anti-vaccination, and their rates were actually lower. And if you look at some of the measles data in Europe, in like 2019, 2018, they had huge outbreaks in like Italy and France, and tens of thousands of cases, so way more than we're experiencing thus far. Knock on wood. So yeah, if you're sending a baby off to Europe or Africa or India or Southeast Asia or one of these places where measles is still quite endemic, it is very reasonable to offer a vaccine to a 6-month-old. You can't go lower than 6 months of age. The safety is established at 6 months. And what is the problem with it? Well, it's not that there's a safety issue of a 6-month-old. The reason is efficacy. Whether it's because children are just a little bit less likely to respond long-term to this live virus vaccine at 6 months of age, or if it has some combination with the fact that mom's antibodies, right, are transferred to infants, and it takes a few months before mom's antibodies go away, and mom generally would have, assuming she was vaccinated, would have given some of that immunoglobulin there. And just like IVIG, remember, you can't give live virus vaccines for about 11 to 12 months after an IVIG dose. because those antibodies that are there will actually bind up the vaccine and make it less efficacious. The same sort of situation could be going on even after 6 months, because sometimes it takes a while longer. So that first dose won't count, meaning if you want to fully vaccinate a child and make sure that they are protected against measles for their life, you will still need to vaccinate them again at 1 year of age, provided there's been a month in between then, and then receive a second dose at least a month after that one. It is important to remember that these vaccines are live viruses, which means yes, they're attenuated. The measles strain was from one of the genotypes, genotype A for those who care, and it was attenuated, so passaged and made less virulent through selection. And so that's to say that a person with a fairly healthy immune system will do very well with the measles vaccine viral infection. However, someone who's immunocompromised, got a bone marrow transplant, is undergoing chemotherapy, has severe autoimmune disease, and is receiving biologics or inflammatory bowel disease or one of those issues where they're immunocompromised or genetics, any of those scenarios, it is not recommended. In fact, it's dangerous to give them a live virus vaccine, especially the more severely immunocompromised. So then the question is, well, what do we do for these people? Like, what happens to these? And obviously, the best thing is for society to have a high measles immunization rate, because then that protects them, and we don't need to worry about it. But unfortunately, we don't live in that world. So what do we do if these patients are exposed to measles? So there's two ways. There's active and passive methods to sort of secondarily prevent or at least attenuate the course of measles should it happen. And if someone's unvaccinated and they're able to be vaccinated, right, they're not immunocompromised, and presumably, hopefully, you can convince their parents that they're exposed and we want to protect your child, and it's within 72 hours of exposure, you can actually give them an MMR, and that will give them the vaccine strain. They'll start to make antibodies quite quickly to it, because remember, there's boosting to the immunity. So you can start making IgM and IgG to measles, and so once the actual wild type measles is starting to get going, you already have train the immune system to at least start fighting it. Not necessarily prevent all disease, but you can at least attenuate the course. Now, what happens if, again, they're immunocompromised, unvaccinated, and just parents decided they didn't want to, and it's over 72 hours? What can you do? Well, if you can convince them that to give them a modern medicine, and that there is some reason to it, and you can do that, then you can give IMIG or IVIG, but the reason we do IM is just so you don't have to place an IV or that kind of thing, and they'll still get the passive immunity. That is, of course, assuming that our immunoglobulin pools that we have have good titers against measles, and for now, we're sitting at about a 90% overall vaccination rate. That means we generally have good measles antibodies in our IVIG. But if that immunization rate really starts to drop, we could start to have lower and lower titers. But hopefully not. And hey, if that happens, there'll be more natural measles, and people will still make antibodies. All right. So I think the next important thing is, okay, so let's say the measles kid comes in, and they have active measles. What do you do? There is this medication, ribavirin. Unfortunately, there's never really been shown to be very efficacious. If somebody is immunocompromised and exposed, or is immunocompromised and given a measles vaccine, we will consider using ribavirin. But there's really no good clinical data to show that it will actually do anything to save that child's life or prevent them from developing severe complications. But vitamin A, I'm sure everybody's heard quite a lot about lately. And where did this come from? Like, how did vitamin A and measles come to pass. So I will show you. It's actually based on some interesting studies. So in the late 80s, a group in South, or I think it was, yes, in Africa, in Zaire, looked at what's different. Why do some children die of measles and others seem to do okay? Is there anything that they can relate to it? And so they did what anybody would do in a study, right? They do multivariate regression. They look at a lot of variables and they try to see which ones seem to correlate with severe disease. And obviously, what they found was younger children, which I think was already obvious, but younger children, less than 24 months, if they already had pneumonia, that was a pretty bad prognostic sign. But what they also found, curiously, was that children who had vitamin A deficiency were at much higher risk of death. So if you see here, right, a vitamin A level less than 5 micrograms was associated with a fatal income with a relative risk of almost threefold, right? So pretty significant relative risk. So of course, not to say it's a cause, it could just be an association, but people did later look, and it does seem like vitamin A is important. So that led to a randomized controlled trial, which was published in the New England Journal, again in Africa, and children who they randomized 189 to either placebo or receiving vitamin A treatment, and those who received vitamin A had a lower risk of mortality by a considerable amount. That's not to say that none of the children who received vitamin A survived. In fact, some died, but certainly at a much lower rate than those who received vitamin A. Oh, excuse me, died at a much higher rate than those who received vitamin A. So, so definitely worth treating patients. Now, if you look at larger studies, for instance, I think there's, if you want to do a deeper dive, you can look at all the references, but let's see here. So I think there's two Cochrane reviews that are pretty good if you want to go through it, one in 2005 and one in 2002. 2002. Which kind of go over what the evidence is. And the reality is that vitamin A is not a magic bullet. It turns out that in children in Africa who are less than 2 years old, it reduces your risk of dying from a respiratory perspective or a respiratory illness. Now, interestingly, a group in Italy in 2021 during an outbreak looked to see how does vitamin A perform in a much more developed nation where there's much less malnutrition, and they didn't find a whole lot of difference between giving vitamin A or not giving vitamin A. That being said, I think it's really important to remember that malnourishment exists everywhere. Obviously, its rates in Africa, India, and impoverished countries have a much higher rate than in developed nations. But hey, even in the U.S., we are not necessarily doing the best in terms of nutrition. There's plenty of kids who are living on fast food, very picky eaters. I am living in LA, and even though it's an apartment, I have to rent still as a pediatrician. I still have very excellent access to nutrition. Now, do I eat enough vegetables even as a vegetarian? No, but that's not to say that I don't have access. But there's so many people living in this country who do not have good access to fresh fruits, vegetables, and that kind of thing, and so could easily have multiple vitamin deficiencies and nutrient deficiencies and are malnourished, even if they're an appropriate weight. All right. And a lot of that has to do with bad access and food deserts and all of these societal problems that we do not have a good handle on. All right. So again, like I said, it is recommended for all children who present to the hospital with severe disease, and the doses are below 50,000 international units for less than 6 months old, 100,000 units for 6 to 12-month-olds, and 200,000 international units for greater than 12-month-olds. Make sure you're looking at international units and not RAEs. because the RAE is an equivalent, and it's, I believe, a threefold lower equivalency. So, don't want to overdose them either. But I think most pharmacies in hospitals will know to dispense the appropriate amount of international units. But it is important, especially if for your patients or public, if they're deciding that they want to do that, that there is a discrepancy. And so if they look at a thing saying, oh, give them 200,000 units, you can overdose. And that brings me to the next point. Vitamin A. I think as we, if we just like pull up the news, right, you can already see that it sort of made its way due to people touting it as a magic bullet for measles. That little kids are getting poisoned with vitamin A, and you can say like, well, but it's a vitamin. How can you poison someone with a vitamin? And that gets back to basic biology, which unfortunately I don't think is all that well understood by many people. Remember, humans are a complex organism, right? We are very dependent on so many different complex systems, which means they need to be in balance, right? We are actually quite fragile. If you look at what we need to survive, right? If your pH, right, is less than 6.8, you die. If your pH is greater than 7.8, you die. So you have like you can survive in a 1 pH range, and if you go out of that, you're dead. And I got news for you: if you think you're feeling well at a pH of 6.8 or even 7, you are not going to be feeling well, and the same goes for 7.8. So really, the actual range that we can live in is even smaller than that. Same with temperature, right? 34 degrees Celsius, you die. If you're 42 degrees Celsius, you die. You have a 10 degree Celsius range where you can survive in, and even then, if you're not around 37, if you're 38 or 39, you feel terrible. If you're 36 or 35, you are going to be shivering and feeling absolutely miserable. And that shows you just how delicate a balance our bodies need to be in. Now, that goes for a lot of things, right? Food, right? I mean, obviously, all of us know the importance of food, right? If we don't have food, we don't have any energy to power ourselves, to walk around, to do anything useful. We can't use our muscles. But obviously, too much food is a terrible thing, right? If you end up eating just endless amounts of food and you eat way too much sugar or way too much processed foods, you're at high risk of cardiac death, you're at high risk of diabetes and all sorts of complications. And the same goes for the opposite side, right? Anorexia nervosa, or people who are suffering from famine. Their bodies cannot handle not having enough calories. So, finding that right balance of food is important. So using that analogy, let's get into the idea that there's can be too much of a good thing and too little of a good thing. Now, when it comes to water-soluble vitamins, you're generally going to be okay, right? I think most of us know, right, vitamin C, they sell those gargantuan quantities of vitamin C. People say, oh, well, I need it, for my immune system. And the reality is, your body's going to control the amount of vitamin C pretty closely. So imagine filling up a gas tank. You're filling up your gas tank. If you just keep filling it, what's going to happen is it's going to slosh over, and your car's going to be fine. You're going to drive. I mean, maybe it'll be covered in gasoline, so don't light a match. But in general, you're going to be okay because it's just kind of spilling out. And your car's going to be okay, and it'll be drivable. It's just going to be expensive because you're just wasting gasoline. The same goes for a lot of these water-soluble vitamins, like vitamin C. If you just eat too much of it, it's going to just come out of your kidneys, right? Your kidneys are just going to excrete it, and you're just going to have spent a lot of money on vitamin C pills. Minus the fact if you go a little overboard, you can end up with a kidney stone. If you would have to go really crazy amounts of vitamin C in order to develop vitamin C toxicity. Similarly, right, vitamin B2, riboflavin, right, essential vitamin. You can eat tons of it, and if you look at your pee after large doses of vitamin B2, that's maybe why you see that bright yellow urine. If you eat like ramen noodles that have been colored with riboflavin, you'll see like bright green urine and go like, oh my god, what happened? I ate a highlighter. Well, that's riboflavin spilling out of your body because there's too much of it. So the trouble, though, lies in vitamins which we can't excrete very easily, and unfortunately, vitamin A is one of them. A good analogy is iron, right? I mean, obviously, iron we need for our hemoglobin, we need iron for all our myoglobin, for tons of enzymes need iron. So we need iron. Iron's an essential mineral that we have to get or we die. But, I mean, there are kids who, get a hold of those delicious Flintstone chewables with vitamins and they just start piling them in and they end up with severe liver toxicity because again, you can die of you can die of iron poisoning. Gets into the liver, can't get out of the body, and causes hepatotoxicity. Vitamin A is a lipophilic or hydrophobic vitamin, which means we don't have a good, easy secretion mechanism. It doesn't come out in the kidneys. It's very slow to come out. So let's have a look here quickly. So where does vitamin A come from in general, right? Most of us will derive a lot of our vitamin A from vegetables in the form of beta carotene. Well, beta carotene, it turns out, is this long hydrophobic molecule, which is non-toxic, right? Because it's not in an active form. At the risk, the biggest risk of it is if you eat too many carrots or squash or something, especially these tiny babies, right? They end up orange, right? So you get a cute baby with an orange nose, and that's about the extent of going overboard with beta carotene. But beta carotene is slowly hydrolyzed in various tissues into its active form, vitamin A, and that can become a problem. Now, you can get dietary sources of vitamin A itself properly, especially in liver, fish liver, right? That's where this cod liver oil comes from. But it is really important to remember that it can be a problem because we don't have a good excretion mechanism. So everything in balance. So what happens with vitamin A? What happened here? So we've got our yin yang. So we have deficiency, right? And then we have toxicity. So vitamin A deficiency, I think most of us will remember from med school, but remember it's important pigment in photoreceptors. So you absolutely need it for vision. It's also important in skin, so people with deficiency will have dry, brittle skin. So it's important for skin and even bones and soft tissues. And it's important for the immune system. As we've talked about, if you have vitamin A deficiency, you are at high risk of measles and probably some other viral infections too. We just haven't made that connection yet. But you can have too much of a good thing, and especially where vitamin A is stored, it is stored in the liver, and so you can end up with acute hepatotoxicity if you go overboard with vitamin A. Right? Everything in moderation. Also, adults who have very high diets in vitamin A, like eat a lot of liver or that kind of thing, they can also develop pretty significant osteoporosis. So it is toxic to the osteoblasts that are important in bone formation. All right, so just be careful with the mass doses. These replacement doses are megadoses, but the idea is, if you do it over 2 days, that seems to be associated with improved mortality and likely won't cause any hepatotoxicity or anything, assuming that somebody has not already been overdosing on vitamin A. All right. So just a few other interesting things. I don't know how relevant this is, but I think one of the relevant to everybody's general clinical practice, but one of the interesting things about measles is, people say, okay, well, it's good for you, but is it really? The answer is all the data we have is no. I mean, obviously it can cause severe pneumonia and encephalitis, but the other thing that's interesting about measles virus is it also likes to infect T and B cells, and which eventually are killed by the other T and B cells that are trying to fight the measles. And that can actually lead to pretty significant declines in antibody levels. And this has been looked at in studies. So you can have up to 73% reduction in your antibody repertoire, meaning all of the bacteria and viruses and stuff your body has been learning to fight before getting the measles. A lot of those memory and memory cells and stuff can get killed, and you end up with a lower antibody repertoire. So as all the evidence does not point towards natural measles being a good thing compared to just an immune response. In terms of, I don't know if anybody's interested, but we can talk briefly about the R0 value as well. Let me make a little new page. So why is measles so contagious? Ooh, I don't really want a whole new one. Maybe I'll do one of these. Yeah, okay. Just copies it. Let's erase you. All right, so we talked about already kind of why you really don't need much measles in each of these tiny little respiratory droplets. So just to review what an R0 value is and where measles is at, an R0 value just means how many people is one. So if you have a population that's completely unimmunized, so just like let's say you're living on, this is a population on an island, never been vaccinated, and somebody comes in with measles, what's going to happen? And so let's say you have like 5 people here. Of course, ooh, that one's a little bit strange. He has a third leg, and that one has no arms. But what the R0 value is pretty simple. It's just how many infections is one person likely to infect. And so if you look at this guy, right, he comes in, let's say Mr. Blue Guy comes in to our red friends, and he's coughing up his measles. The R0 value means how many people is this guy going to infect on average for the duration of his illness. And if you've got a virus like smallpox, it's 5. That's smallpox's R0 value, we think. Flu is somewhere around there too, can be up as 10. Coronavirus, COVID, actually, interestingly, as it's been evolving, has gotten higher and higher R0 values and become more and more contagious. No matter what it is, measles is 16. Somewhere around 16. 15 to 20 somewhere is the estimate, but 16 is, I think, roughly in that range, which means one person would infect 16 others. And you can imagine that now these 16 people are coughing, and they meet, they're each going to infect 16 more people. And then those 16 are going to infect 16 more people. So you can see how this R0 value will grow in a geometric sense. Now, obviously, there's components, right? The population has to be naive. No one can be immune. Some of these cases will start to die out, or not necessarily die out, but at least become immune and stop infecting. So, and then they'll be immune, so that if one of these people tries to reinfect that, it's not. So it really just is important for that first value. But that's the simple idea behind it, and why it can grow so quickly, right? 16 times 16 times 16 times 16, right? You can imagine in a giant city of millions of people how fast that can begin to spread, and why it's very difficult to tamp down infections, especially the more contagious of diseases. All right. Well, I think that's all I got. Let me know if this was helpful to you. If you have any questions, you can leave a comment. I'll do my best to answer them. I can't say that I'm going to be able to answer everything, but I'll do my best. And if you think this was helpful and would want to see it with other vaccine preventable diseases, I had this idea for a little while to kind of do a whole series, but let me know if this was too in-depth and boring. That's also helpful feedback. All right. In the meantime, good luck. Just keep in mind, I think probably the most important things to remember about measles is it's going to present like a common cold or like a severe common cold at first. And if someone's unimmunized, to really keep that high index of suspicion. Oh my gosh, this could be a measles case, especially if there's an outbreak going on. And do make sure to look in the mouth when that's going on to see if you see any complex spots. Although again, they might not be there especially in the first couple days. And do your best to try and spread the word that vaccination is really the best way to prevent it. Obviously, you can only do so much as a doctor, and sometimes, unfortunately, people have to learn the hard way, and that's hardest for the reality that some patients, like undergoing chemotherapy, cancer, immunocompromised, they are unfortunately the victims, and tragically get it despite that. Okay, goodbye. Good luck.